Take another look now and take some time for hemp. Don't cut trees for paper, cause it hurts the environment. Stop deforestation, yeah, it's time for hemp. Oh, an acre of hemp makes 20 barrels of oil. No need for pesticides to poison all our soil. People got no food, they got no clothes, they got no rest. Well, right now it's time for hemp.
Thank you for taking time for hemp. I'm your host, Casper Leitch. You are listening to Time for Hemp on Tumblr, SoundCloud, iHeartRadio, iTunes, Google Plus, and a variety of other platforms that allow you to download our content into your smart devices. Also, check us out on Twitter and Facebook, and share us with your friends. It is Monday, and on Monday we like to celebrate all the wonderful things that cannabis can do for your body, your mind, your soul, and your spirit. And we put a spotlight on the amazing team at Patients Out of Time and their founders here on the big broadcast, Lynn, Mathre, and Byrne. Lynn and Al, thank you for bringing your talent and your education to our audience here on Time for Hemp.
Well, it's certainly our pleasure, Casper, and I really appreciate you calling it cannabis. I can remember the days when that wasn't what you called it. Anyway, this is Byrne. I'm here with Lynn Mathre. We're co-founders of Patients Out of Time. We're here to represent Patients Out of Time. You can find information about what we do at medicalcannabis.com or patientsoutofTime.org. But the short story is, for the past 20 years, we have educated U.S. healthcare professionals, doctors, nurses, pharmacists, and the U.S. public about the therapeutic and clinical uses of cannabis and the endocannabinoid system. We are still the only corporation, nonprofit in the country that, under the authority of the American Nurses Association and the American Medical Association, holds conferences that supply the attendees, the doctors, pharmacists, nurses, etc., that attend, with continuing medical education credits, and we've been doing that since the year 2000. Doctors, nurses, etc., can also obtain those valuable CMEs. These are education credits, folks, that doctors and nurses and other healthcare professionals generally need to keep their licenses current wherever they practice medicine. And the ANA and the AMA sees the need for having this education, and we do it online. Doctors and nurses can take these courses online at themedicalcannabisinstitute.org. I'll repeat that one time, themedicalcannabisinstitute.org. As followers of this show know, today we talk to medical cannabis experts, people that have been involved in the medical cannabis business in some form or other as researchers, clinicians. And our other show that we do this every week, as you know, we tend to interview patients, their caregivers, and we specifically concentrate on U.S. military veterans and their families. Today we have an author, a medical doctor, Dr. David Casarett. He comes to us, and Lynn and I have only talked to him just now, so this is a new expert for us. And I'm not sure I could really qualify Dr. Casarett as an expert, but what he is a man who saw that he needed to know something, and he went out and learned about it. So, Dr. Casarett, David Casarett, welcome, sir.
Thanks. Great to be with you.
And right away, I know from reading your bio here that you are a hospice palliative care doctor. I applaud that. We need more of you guys, and we work with many of your profession over the years. Doctor, try and give the listening audience, keep in mind it's international, so that, where you're from. Everybody knows you're a United States citizen, but, how'd you grow up? How'd you become a doctor? Why palliative care?
Sure. So I'm at the University of Pennsylvania in Philadelphia, where I'm the director of the Hospice and Palliative Care program here. I actually got into palliative care after I finished a residency in internal medicine because it seemed like there was a lot of good work that needed to be done. There were a lot of other specialties, cardiology, neurology, that were all about basic science, but palliative care, the science of making people as comfortable as possible, supporting them, helping them with their decisions, that was a science that was really, really very new, and I realized that there was a huge contribution I could make, both in terms of research and policy and ultimately writing. So it really struck me as a way I could do some good.
Was that your motivation, becoming a medical doctor as opposed to a cowboy?
Yeah, I think that was a lot of it too. But honestly, for me, one of the attractions of being a physician is not just being able to help people, but it's intellectually a lot of fun to be a doctor. It's always stimulating. It's always challenging. It's a chance to meet people at various stages of illness with a variety of problems and learn a lot from them along the way. And I just can't imagine getting that same stimulation and satisfaction and challenge from being a lawyer or an accountant or a cowboy.
Okay. How long have you been in the profession, sir?
Well, I graduated from medical school in 1993, I guess. Is that right? Yeah, pretty much. Then did a residency fellowship, so I've been at the University of Pennsylvania since 1999, first as an instructor, now as a full professor.
Oh, wow. Well,
yeah, I'm thinking you're so young, and then I'm thinking, well, but that's a lot of experience. The sad part is we're too old.
yeah, I think that's part of it. Well, listen, you're also an author, and really that's the reason that we asked you to speak with us today, is because you just published a book, which is getting some attention. And frankly, sir, you'll find me a pretty honest guy in this conversation here, but I really like your subtitle. And I'd like to read the subtitle first, folks. The subtitle is A Doctor's Case for Medical Marijuana. What I don't like is the name of the book, which is Stone. There we go. The other thing that I'll say about this, and you've heard, everybody knows that I say this, but I have to say it, Doctor, is we don't call it medical marijuana, we call it medical cannabis, because in our world of science and research worldwide, that's what the researchers, the scientists, and the clinicians call it, is cannabis, and that's the way it appears in the medical dictionaries. I understand the euphemism and we understand the interchangeability, but you'll hear us talk about cannabis. But what I like to see in this book is that three-letter word, for. You're for medical marijuana, medical cannabis. And I'm not sure that you went out with that opinion when you started your search, did you?
No, I didn't. And if I could just back up and say something about the title. So you're not the first people who have pointed out to me either that Stone title is not your favorite. Clint Werner and Donald Abrams, many of your listeners will probably be familiar with, were kind enough to help me in doing some of my research, help me in changing my mind about medical cannabis, and also read a manuscript of the book to give me some advice. And they both really, really hated the title. But the title was to make it a little bit humorous and to appeal to readers who wouldn't necessarily pick up a book that was titled A Doctor's Case for Medical Marijuana or A Doctor's Case for Medical Cannabis. And we really wanted, meaning me and my publisher, wanted to reach an audience of people who wouldn't necessarily read those books with those titles. And I should say the cannabis angle, for better or for worse, I think we all know that marijuana is what it's called. So in the war of the Google searches, when people search for advice about smoked plant that used to be called cannabis, they don't search for cannabis, they search for marijuana. So I'm fully with you, and I understand all the arguments for not using stoned and for using marijuana, but that was kind of the reality.
Yeah, it's not a big thing, and I thought it was a publisher thing, and it sort of makes sense. But I just thought I'd bring it up. And Don Abrams and Clint are personal friends of ours for years, and we all agree. Anyway, what I would like to point out about to the public about what you just said is very interesting. If you go on a Google search and you Google medical marijuana, you will go off on a particular highway. If you Google search therapeutic cannabis, you will go off on a totally different journey. And I think that is a big mistake that people make in the medical professions and in the journalistic professions. Do not Google medical marijuana. You'll go to High Times and all of those folks who are great folks and they talk medical marijuana. But if you really want to know the science and where the science is located, you go to therapeutic cannabis. So please take that under advisement. Well, I'm sorry, so go ahead, please.
No, I was going to, this is Mary Lynn. I was just going to say that I understand where you're coming from. Back in, 97, when I put out the book that I edited with numerous other contributors, I wanted to call it Cannabis the Medicine Plant, and it ended up being, medical cannabis.
Medical marijuana.
Medical marijuana. Medical cannabis, but the legal, historical, pharmacological overview of therapeutic use of marijuana. And they were saying, we need to get all those words in there so people will find it. But I hear what you're saying. Stoned, I think, it will attract those who think it's bunk and at least can get to the book and start reading. Because I think a lot of what you did, it's kind of similar to Sanjay Gupta. Finally, let's take a closer look at this and see what happens. So was it patient stories, or what actually got you on the journey?
Yeah, so that was the original question before I took us on that tangent. Yeah, I started out as a skeptic. About a year and a half ago, when I first started this, I thought medical marijuana was a joke, that it was just an excuse for people who wanted to get high, to get a safe, reliable supply of marijuana. Honestly, that's what I thought, and I'm admitting that publicly because I think I wasn't alone. I think a lot of my physician colleagues and a lot of members of the public think exactly the same thing. It was actually a patient who asked me, this is a woman in her 80s, a retired English professor, who asked me whether I thought medical marijuana might help her. She had advanced pancreatic cancer, had pain and nausea, and I gave her the standard line that I learned in medical school, which is that marijuana is an illegal drug, it's addictive, and there are no medical benefits. And you asked me what started to change my mind, and it was actually her, because she reached into her handbag and pulled out a couple of reprints of articles that have been published. One was by Donald Abrams, you mentioned earlier, a study of vaporized cannabis on pain scores. Another was by a researcher I interviewed for the book named Barth Wilsey at UC Davis, who did a randomized controlled trial of vaporized cannabis for neuropathic pain. And, both of these were well-done studies. One of them was a randomized controlled trial published in respectable medical journals. And remember, just a few minutes ago, I had told this woman, there are no research studies, there's no evidence of medical marijuana. And this patient of mine is basically showing me that she knows the literature on medical cannabis better than I do. As a palliative care physician, I really should know more about managing symptoms. So I promised her I would look at those articles, I'd find others. And I did. I found other articles that had been published, talked to people like Donald, like Barth. Raphael Meshulam was kind enough to spend some time with me at his laboratory in Jerusalem. And many others, and it was those sorts of conversations that made me realize, first, that there's really a science there. It's not just about getting stoned. And there's real evidence. There are good clinical trials.
Yes, there are. There's, just for information, there's 80,000 pages of peer-reviewed cannabis science literature at www.drugpolicy.org. It's sort of an old list. It's probably dated by 3 or 4 years. We've expanded the list. Patients at a Time holds 100,000 pages now of peer-reviewed literature, and it has been supplied to the federal government as part of an ongoing suit that some of us have against the feds on this issue. But there is research. What people mention, Doctor, when they talk about research is American or U.S. research, and that is rather limited. When I discuss 100,000 pages of peer-reviewed and published literature, I'm talking about the world.
Sure. I think it's no secret to any of your listeners that the United States is kind of behind the times in terms of research. By some estimates, the National Institutes of Health in the United States funds very little, relatively, research on therapeutic applications of cannabis. They're really more interested in studying its risks, particularly risks of addiction. But there are people like Raphael Mechoulam, arguably the grandfather of medical marijuana science, who have been doing this research literally for decades. And I think the United States is really at risk of being left far, far behind the rest of the world if we don't rethink attitudes and regulation of how cannabis can be obtained, how it's scheduled, and how research can happen.
Yeah, we couldn't agree more. And just to brag it up a little bit, back in 2004, we had a conference here, was keynoted here being Charlottesville, Virginia, at the University of Virginia Medical School, Nursing School, and School of Law as co-sponsors. And Dr. Mechoulam was the keynote speaker, and I am the moderator of this series, and I introduced Dr. Mechoulam as the grandfather of medical cannabis research, and that has stuck with him. And I'm glad it has. It's one of those monikers that is well-deserved, and that man and his amazing laboratory staff have generated incredible research, and I know that you talked about some of that, or you wrote about some of that in your book. But sir, right now, we're going to have to take about a 4 or 5 minute break, depending on how it goes, and we'll be back to talk to you again, sir. And folks, we're here with an interview with Dr. David Casarett, medical doctor, who is the author of Stoned, a doctor's case for medical marijuana.
You are listening to the Time for Hemp Global Broadcasting Network. Please share us with your friends.
THCF Medical Clinics are the premier physicians clinic in the United States. THCF has offices all across the United States from Hawaii to Michigan. THCF Medical Clinics has helped approximately 150,000 patients obtain their medical marijuana permits to legally possess, grow, and use medical marijuana. If you have chronic pain, multiple sclerosis, or any other neurological degenerative disease, or if you have any gastrointestinal disorders such as GERD, irritable bowel syndrome, or if you have AIDS, cancer, spastic disorders, seizure disorders, or glaucoma, call us at 1-800-723-0188 or visit us online at hemp.org. Again, the number is 1-800-723-0188 and the site is hemp.org.
This is a message of a world in war. This is a message of a world in pain. This is a message to our global leaders. This is a message, a cry out for freedom. This is a message of a world in war. This is a message of a world in pain. This is a message to our global leaders. This is a message, a cry out for freedom fighters. What we require, souls on fire.
More fire, more fire, more fire, fire.
Freedom fighters, what we require, rebels fire.
word like this. The act of Noah was already a sign. A warning of Jah to start an evil mind. Jah, don't let it happen again. We already got us a second chance. We have to take a risk with lives in our hands. We only live once, we must make it better. Global freedom and peace is the answer.
This is a message of a world in war. This is a message of a world in pain. This is a message to our global leaders. This is a message, a cry out for freedom. This is a message of a world in war. This is a message of a world in pain. This is a message to our global leaders. This is a message, a cry out for freedom. Fighters, what we require. Souls on fire.
More fire, more fire, more fire, fire.
Freedom fighters, what we require. Rebels fire.
More fire, more fire, more fire, fire.
We have to stop the killing and fighting. All over the world people are dying. Children are hungry and always crying. Oh Mama Africa. Some people over the world searching for solution, but Diablo is showing the cross of the war. Why using bombs and bullets where to the ball? Self-destruction of our own human species.
This is a message of a world in war. This is a message of a world in pain. This is a message to our global leaders. This is a message, a cry out for freedom. This is a message of a world in war. This is a message of a world in pain. This is a message to our global leaders. This is a message, a cry out for freedom. Fighters, what we require. Souls on fire.
More fire, more fire, more fire, fire.
Freedom fighters, what we require. Rebels fire.
More fire, more fire, more fire.
You've been listening to the Rough Star family called Freedom Fighters here on Time for Hemp. This is the Time for Hemp Global Broadcasting Network, and this is the Time for Hemp Broadcasting Show. And we are a team of people here on the Time for Hemp Network, about 20 people, all dedicated to ending prohibition all around the world. And like a good joint, we are best when shared with friends. With that said, we're going to get back to our joint conversation here on the joint broadcast. Don't forget, anytime you hear the word joint on the big joint broadcast, nearly 2.5 million people all around the world jointly light up their bongs, their pipes, their vaporizers, or twist a joint to take Time for Hemp. So with that said, I'm going to enjoy my joint while you guys get back to your joint chat on Time for Hemp.
Coming near the record of saying joint in 5 sentences, Casper. We're back, folks, with Dr. David Casarett, medical doctor who wrote a book called Stoned, A Doctor's Case for Medical Marijuana. And Dr. Casarett is a palliative care, a hospice expert. That's where he concentrates. We've discussed that just a little bit. But in the book, Doctor, I got the repetitive idea that the word high, H-I-G-H, that you use and others use to describe what happens to a person's feelings when they use cannabis was used in a very pejorative, a negative sense. And I have emphasized to folks over the radio and in other places that I think what we really need to say, I would like to say anyway, I'm up for argument, is that when I use cannabis and other patients use cannabis, I think they feel a calm, a relief, a joy. I like the word joy. And I noted that even though your book said, I implied high meant negative throughout your book. Finally, on page 230, right near the end of your book, you said, well, wait a minute. This is euphoria is what these people are feeling, which is joy. Now, as a hospice doctor, how do you feel about making people feel good when they have just a very little time to be with us? That's a good thing, isn't it?
Oh, sure. I mean, I think a lot of situations it is a good thing. Although, keep in mind, I mean, the way to define whether it's a good thing or not is what it means to an individual person. So some people want to be, and I've taken care of many of these people, they want to be absolutely clear-headed. They don't want to feel high. They don't want to feel that artificial sense of joy. They just want to be totally clear. They'll even refuse to take pain medications like opioids because they want to be clear. On the other hand, some people do want that feeling in greater or lesser amounts. So I would never ever say that that feeling, whatever you call it, is a bad thing. But I would caution us that what might be good for one of my patients might not be good for another. But I think we're on the same page that the people who should be deciding how you want to feel in your last days of life should probably be that patient, not the doctor taking care of that patient, not the government, but that patient. And I think you're right. Many patients I've talked to would actually like that very much.
Well said, Doctor, and I agree completely with you, and I'm glad. I'd be happy to have you as my final doctor from what I just heard about you. Let's go to addiction. I think here we have something to discuss. You leaned on the Fraser study. That withdrawal was hard, that it was even sometimes violent. I don't know.
That was a funny study. I'm not sure we should take it seriously, but it was pretty funny.
And I think maybe I agree with you there. Maybe we shouldn't take it too seriously.
Well, then why bring it up?
No, I'm hearing this study. But Alan made a comment, and I thought, I'd really like to go look at that study even more. But a point being, when you're doing a study with soldiers and that, it's like, gee, I wonder what their lives were before that. Because, I look at today and just think of a lot of combat vets that are trying to deal with their post-traumatic stress symptoms and having such a hard time. And
tell the people what the Fraser study is. They don't know what we're talking about.
Well, actually, David, Dr. Casarett, you could probably explain it better since you really looked at it. I was learning it more from your.
Please explain it, Doctor.
Sure. So the quick summary is it probably doesn't even deserve to be called a study per se, but there was a physician by the name of J. Fraser who, this is going back almost 100 years ago now, found himself caring for Indian troops who had been mobilized from one region of India somewhere else, who had been, he says, regular users of cannabis, and then suddenly, he says, had their supply of cannabis cut off because they were relocated. And what he then proceeds to describe was what he saw as a syndrome of cannabis withdrawal. And as you can tell, I'm putting quotes around pretty much everything I'm saying because we don't really know that what he's describing really was cannabis withdrawal. Could it have been withdrawal from other substances? Could it have been the result of people who stopped using cannabis and then turned to other drugs? So what he was really seeing was intoxication by other drugs that they weren't familiar with. We don't know. So that story was really in the book, partly as a way of getting people's interest, but also as kind of a nod to what a lot of the reefer madness advocates think. I mean, I think many people out there who are very skeptical about medical cannabis in general would look at that study and say, yep, exactly, I told you. So I thought it was useful to start with that story and then to unpack what we really know. And I also mentioned the DSM-4 criteria for cannabis withdrawal, which are much, much more sedate than all of the craziness that Fraser describes, of people being confused and paranoid and delusional and, frankly, delirious, firing guns off. Like, this is not something that ever made it into the DSM-4 criteria. Not something that I think most of us ever see in clinical practice. So the reality, if there is a cannabis withdrawal syndrome, it's much, much more benign than anything that Fraser describes.
Yeah, and I'd certainly agree with that. I think, as I talk to people in the addictions field and just kind of remind them, or people in the healthcare field in general, it's like, we just don't admit patients to the hospital for marijuana withdrawal, cannabis withdrawal. It's just nothing's going to be so severe that require hospitalization as you would with alcohol or possibly benzos. And the fact that, patients with their opiate addictions just feel so terrible they can't, they go back to using opiates. But yeah, and I think, the researchers, some of the researchers who get into that, I know they're stuck. I guess coming from the addictions field, I see a lot of people in the field who are in recovery themselves, and they did it through abstinence only, and they believe with all their heart that that's the only way to do it, and cannabis is this drug on the slippery slope. And they kind of, I think they help reinforce their belief in that, because every time they do an assessment, they find out that patients using, you've got opiates and you've got this kind of problem, but you use marijuana too. You've got a cocaine addiction, it's really causing these problems. You use marijuana too. And in reality, the addicts, for the most part, kind of find that a little silly, but many of them, they do use cannabis, and a lot of them use it for the sake of when you can't get your heroin or your OxyContin, the cannabis helps with the withdrawal. And in many ways, it's the research we're seeing is more of looking at it as exit drug than the gateway drug. Yes, they tried it, but hardcore addicts generally are going to go for something with a bigger bang that really changes the way they feel. So it's a tough one, and I think the researchers then, when they look at withdrawal symptoms, very often it's giving someone a blocker. So instead of cannabis, which stays in your system for a while and slowly gets out, and so the symptoms aren't that extreme, if you give someone a blocker, you do see it more. But again, it's minor type symptoms.
Anyway, that's addiction. So I think that basically what I'm hearing as a layman here is that the addiction probably is way too ridiculous a word to use, and withdrawal symptoms are not anything that we shouldn't ignore them, but we shouldn't particularly feel them.
And some people will probably have, and they do. I mean, I think some people have had, problems with it. It's just, when I put it in with all of the other drugs out there, this is just such a minor problem comparatively.
Doctor, another subject that is big on our brains, Marilyn and I are both Navy veterans, and we do a lot of work with veterans in cannabis and the Veterans Administration and at the national level, and have had some real successes there, but we still have a big failure going on. But you did look at, I believe, quite extensively for your book, the treatment of post-traumatic stress with cannabis. I don't think it was necessarily centered on veterans. I think it involved other people, if I recall correctly. But can we discuss that a little bit? What was your overall opinion? How did you come out with that one? Good, bad, medium?
Yeah, so I think the short answer is we don't know yet. And I think one of the biggest risks of this field is to look around and say, well, I don't see any good randomized controlled trials, so it doesn't work. And I think, given how hard it is to do research, that's really not a good approach. I mean, I will say that I looked pretty hard for a good randomized controlled trial using medical cannabis to treat PTSD, and I couldn't find one. I found one retrospective survey study that asked, I think it was veterans, although I wouldn't swear to that, whether after they started using medical cannabis, whether they felt better, and many said they did. There was another prospective study in Israel, I believe, that used, I think, smoked marijuana, fairly high concentrations of THC, above 10%, I think, that found that those people in that study felt better with reduced PTSD symptoms. But in terms of the kind of randomized controlled trial you'd want to see, if you want to be sure that it actually works, as far as I know, those studies haven't been done. Many of your listeners are probably aware of the struggles of Dr. Sue Sisley, who has been trying to do exactly that randomized controlled trial for, 4 or 5 years now, and has just faced enormous challenges. She's got the funding. My understanding is she's got the funding from a foundation to do the study, but it's a matter of jumping through all the hoops to get approval from a university, from an institutional review board, and mostly from the federal government to get that approved. So as far as I can tell, we don't have the randomized controlled trial data yet to say that it works. I do spend some time in the book, in Stone, talking to some researchers who are very interestingly not only in using medical cannabis to treat symptoms, but also to rearrange the way that memories are formed and stored, which might even help to be used in cures of PTSD alongside behavioral therapy. So there are some people out there who think that there might be enormous benefits, potentially, far more than just treating symptoms of medical cannabis. But I think there, too, we don't know yet. Having said that, though, I've talked to a lot of patients, many of them veterans, suffering with severe PTSD symptoms, and they're telling me, all right, so fine, there's no randomized controlled trial data out there, but I think it works for me. It's not doing me any harm, and it's much easier on me and my system than all of these other drugs the psychiatrists prescribe, so why shouldn't I be able to use it? And I know there aren't any randomized controlled trials, but that argument's pretty hard to refute. You know, if a patient came to me and I was able to make a recommendation in Pennsylvania, which I'm not now, I would probably be pretty sympathetic and say, well, yeah, you know, if it works for you, until we have evidence from randomized controlled trials, let's try it.
Well, you could always do an N-1 with that patient as his doctor, could you not, sir?
Oh, sure. You're referring to N-1 trials in which people are started and stopped on a medication. You know, there are other opportunities as well. I've been working with Donald Abrams and others to try to create a website, which right now is open, although it's still in beta testing, marijuanaresults.org, which is a site where patients will be able to go to describe their experiences with medical cannabis for various symptoms that then other patients can go to learn from the experiences of patients like them. And then ultimately, hopefully, researchers will be able to learn from those experiences. So if you're a researcher and you're thinking about doing a clinical trial, you'd be able to log onto the website and realize, gosh, there are 1,000 reports of medical cannabis for Parkinson's. You know, we should really do a randomized controlled trial for that, not to substitute for randomized controlled trial data, but to try to fill in some of the gaps, because it's going to take a long, long time, even if the government in the United States turns around right now, or other governments, frankly. It's going to take a long time before we have the kinds of clinical trial data that we need. So I think patients really need some advice and support now.
Yeah, unfortunately, I think you're correct. The best data that we have, actually, I believe, is coming out of Israel. Back in 2010, we had the Assistant Minister of Health from
2012, yeah.
2012, I'm sorry. The Assistant Minister of Health came and presented the results of work that they're doing in Israel with military personnel who were head injured with TBI problems, actually administering cannabis to them on the battlefield, having their combat medics give them a cannabis solution right on the battlefield if they've been head injured, and then which was very successful, probably the anti-inflammatory effects. And then that's his guess, not mine. And then also the use of cannabis for post-traumatic stress. Now, I say post-traumatic stress, and this is just me. 20 years ago plus, sir, I was a combat counselor for Vietnam vets. I worked for the Agent Orange people and the VA, and I was a counselor and with non-vets, all combat, mostly men, some women, all women were nurses. And what we learned as peer counselors and counselors, that first thing that we saw was that these people were really messed up on other drugs and alcohol. And the introduction of cannabis to them generally brought them way, way down in usage, if not completely eliminated their pharmaceutical opiate use, and greatly reduced and eliminated in some cases their alcohol use. And this was universal to the hundreds of guys that we serviced in Appalachia. And then I I have been diagnosed with post-traumatic stress from my experiences in 24 years in the military, not just Vietnam. And the results that we would hear from these folks, we were hearing a mirror of ourselves. They were describing what was happening in their brain, and we already knew it. So I'd like to come back after the break and discuss with you a little bit about whether this is really a disorder. That's where I'm going with this, the D, if it's a disorder or not. But until that time, we need to take a break, and please, folks, cooperate with and support our advertisers. If without them, we wouldn't be here. We'll be back in just a few minutes with Dr. David Casarett.
Listening to the Time for Hemp Global Broadcasting Network. The only broadcasting network dedicated to ending the global war on drugs on iHeartRadio.
Your source for quality cannabis and sativa seeds. Serious Seeds are the creators of legendary strains like AK-47, Bubblegum, Chronic, Cali Mist, and White Russian. The AK-47 is probably the most awarded strain on the planet. The high THC content of AK-47 makes it the perfect medical strain for patients seeking quick pain relief. Cali Mist is an almost pure sativa. Female medical cannabis patients have reported that this strain helps relieve menstrual cramps. Serious Seeds just acquired another Dutch high-quality seed bank, Magus Genetics. From now on, Serious Seeds can offer you even more award-winning strains. The fine folks at Serious Seeds strive to breed the best cannabis genetics that they can find, so patients can rely on the effectiveness of their medicine. Go to SeriousSeeds.com to grow your medicine. That site again is SeriousSeeds.com.
Well, thank you for taking time for hemp. We've been enjoying a great conversation today with our friends here from Patients Out of Time. I want to remind you that we are heard all around the world at timeforhemp.com, and we are a team of people who are dedicated to ending prohibition all around the world. Please share us with your friends. I'm going to get back to our joint conversation with our joint friends here on the Big Joint broadcast here at Time for Hemp.
Well, thank you, Casper. We're back with Dr. David Casarett, the author of Stone, A Doctor's Case for Medical Marijuana. And I just wanted to finish up with the D routine. In the years that we spent, us, the council spent, we began to see the D was a misnomer, and it didn't apply. It's a medical term, but I'm happy to see that a lot of researchers and scientists around the world are now dropping the D, making it a little D, replacing it with stress syndrome, more appropriate. We never thought in our time as counselors and as folks that had been labeled with having post-traumatic stress that it was a disorder at all. To us, it was a very normal reaction to an abnormal situation. For some folks, trauma is a one-time event. They get in an automobile accident or some horrific fire or some awful thing like that. for a soldier or sailor or airman, it's a trauma every day, maybe 3 or 4 a day, and then you get up tomorrow and you do it again. And it's a whole different world of trauma. And what we found is that the reactions to that sort of behavior or that sort of environment was normal. We're reacting to an abnormal situation, but our reactions were normal. So we like to drop the D. So when you think about post-traumatic stress, whether it's for a military or a civilian, think about it not being a disorder, but a reaction to an abnormal stress, and it's a syndrome. It's the thing that people will exhibit. So in your travels, Doctor, you travel a lot of miles, you talk to a lot of people, you went to a lot of states. Were you surprised about cannabis? Were you honestly surprised?
Well, I was certainly surprised that it offers some medical benefits. Like I said before, going in to this process, I really didn't think there were any medical benefits at all. So I was surprised to see that there were, and even more so that there were good randomized controlled trials, particularly for conditions like neuropathic pain due to nerve damage, or sometimes the nerve damage and spasticity that occurs with conditions like multiple sclerosis. There's actually pretty good randomized controlled trial data of either smoked or vaporized whole plant cannabis or studies of selected cannabinoids. And I guess that surprised me because I didn't think there's any clinical trial evidence at all, and B, because those syndromes, related to neuropathic pain or hyperalgesia or spasticity tend to be really tough to treat. Opioids don't work so well. So-called muscle relaxants that are often used for muscle spasticity in multiple sclerosis aren't really so much muscle relaxants. They're more generally sedatives, and they just make people feel really sleepy and miserable. So the idea that not only could medical cannabis actually be effective, but it can be effective in a set of conditions that traditional medicine, pharmaceutical medicine, isn't very effective in treating, that was a really neat, eye-opening surprise to me.
Well, you also had some interactions with various patients who were using it for various reasons. Some were, pain control, I think, was a big one that you ran into, which is what I hear all the time, and frankly, I use for pain.
Sure, so a lot of people using for pain, neuropathic pain in particular. I think other sorts of so-called nociceptive pain, people certainly use it for that, although there are other drugs, even drugs that are pretty boring, run-of-the-mill, like non-steroidals, like ibuprofen or Tylenol, work pretty well for regular run-of-the-mill pain. It's the uncommon or less common pain syndromes like neuropathic pain or regional pain syndromes that are really hard to treat. People don't respond well to opioids. They don't like the toxicity of opioids. And I met a lot of people who turned to medical cannabis partly because they weren't getting relief from the medications that their physicians had prescribed, but also because sometimes they were just getting way more side effects and toxicity with those drugs. And they told me it wasn't worth it. Morphine didn't really help that much. It made them feel sick, nauseated, constipated, confused, and they were looking at these sometimes multiple pill bottles that they got from their physicians thinking, this really isn't doing me any good. And so they turned to medical cannabis, partly for relief, but partly to avoid some of those side effects that they were getting from so-called legal drugs.
Okay, a couple of things before we have to quit here a little bit. We want you to put out a URL or whatever you'd like, Doctor, about where these folks can get a hold of your book. Do you have something for them?
Sure. So the title of the book is Stone, The Doctor's Case for Medical Marijuana. It's available at Amazon, Barnes & Noble. They can also go to my website, davidcasarett.com, and then find more about the book and other books that I've written there.
For those who don't know, that's David Casarett, CASARETT.com.
David Casarett. And Doctor, a couple of things more here. You said earlier that in medical school, I believe you said something like, I was taught that people use cannabis because they want to get stoned and the medical thing was an excuse. What do you think now? Should the discussion of the endocannabinoid system and the uses of cannabis therapeutically be discussed or taught in medical schools?
Well, I certainly hope so. Medical cannabis is now legal in 23 states, plus the District of Columbia. In the United States alone, other countries, obviously worldwide. I think physicians should assume, as I've started to assume, that my patients are using it or maybe using it therapeutically. And so I really need to know what its potential benefits are, what its risks are, so I can provide my patients with good advice. And, it's not taught in most medical school curricula now, but it really needs to be, not just the clinical evidence, but the science of how it works, because physicians and other healthcare providers can't support their patients if they don't know what their patients are using or how what they're using actually works.
Well, you give a lot of interviews and you talk to a lot of people, and you're going to talk to more because you're a very influential man in what you do at the university and all. And are you bringing that up? Are you saying to your peer group and the people that you speak to that they need to get this education?
Yeah, I'm certainly trying. And to some degree, I wrote Stoned for my physician colleagues, too. I mean, I'm hoping that people in the general public will pick it up. But I'm also hoping, and many physician colleagues I know have read it and said that they've learned a lot, too. But a book is just one small piece of the puzzle, I think. We need to get medical schools and state organizations thinking about this and thinking about it in a different way. I think many state organizations, for instance, of physicians, are happy to think about and teach about the addiction potential and other risks of medical cannabis, but they're not quite ready yet to think about medical benefits. And I think if you teach about one, you should teach about both.
Yeah, there's an old quote by Todd Nicoria, a physician who is really a leader in medical cannabis, but he said it was something to the effect that we should be thinking about cannabis as a medicine first that may have some psychoactive effects rather than, a drug of abuse that may have some medical effects. And I think that is it. It's trying to literally flip people's thinking about this plant.
And Todd was a psychiatrist on our board of advisors. He's now deceased, but he was a leader in this field, and he spoke out. He used to work for the federal government. He's a very famous man. Doctor, we're going to have to quit here in a few minutes, but I'm just wondering if again, you found out about pain. Was there anything else in your journey that you were surprised about or that you're intrigued about, you'd like to know more about the medical use of cannabis on humans?
Sure. I think we've talked a little bit about the role that medical cannabis might have in treating PTSD, and I hear what you're saying about that D at the end. But post-traumatic stress syndrome, or whatever else you want to call it, is very common, and in my experience is a very common reason why people turn to medical cannabis. And so I personally would love to see more research. Sue Swisley in Arizona has been trying for a while to do a clinical trial of cannabis for PTSD, and hopefully finally is making some progress. But there's so many people out there using it for that purpose. We really need some data to tell us, does it work? How does it work? Does it work more effectively for some people than others? There's way too many people out there using it not to know about whether and how it works. So that's one area I'd love to see more research really, really quickly.
Yeah, I think we all agree. You don't know it, but we agree with you. In your book, you make the point that people that work in the medical cannabis industry, dispensary workers, or however we want to characterize that field, needs a lot of education themselves, needs a lot of more structure. We need to emphasize, I think, laboratory analysis of this plant material that everybody is using as medicine. We agree on that?
Yeah, I think so. Although I will say there's some dispensaries that I went into in which the dispensary staff really know their stuff. I mean, these guys were really, really good. They knew far more about medical cannabis than the average person in the general public, and probably more than most physicians I've ever met. So there's some who are really, really good. I don't mean to dismiss the entire field, but there's some for whom this is just a way to make a quick buck. So I think some way to level the playing field and make sure that dispensaries, as you said, really do test so people know what they're getting. And then making sure that the staff are equipped to give people the kind of advice that they need. I think that would be great. And it would do a lot to help legitimize the field rather than what it is in at least some places right now, fly-by-night operations that set up shop and basically sell marijuana without much advice or guidance. It doesn't have to be that way. Lots of times it isn't that way. But until there's a little bit more structure there, the opportunity to make a quick buck is going to be too much for a lot of people to resist.
Well, Doctor, thank you very much for coming on with the show with us tonight. Today it was really informative. I'm glad you're a doctor for medical marijuana, and I really applaud your coming out publicly and saying that. There's a lot of your peer group is sort of still hiding in the shadows, and I respect what you've done here greatly. And if Marilyn and I can be of assistance to you, or we can get together for a beer or something in the future, we'd love to. But until then, sir, thank you very much for coming on board.
Oh, my pleasure. Really enjoyed the conversation. Appreciate it.
Okay, sir. And then, folks, you can find information at Patients Out of Time at medicalcannabis.com or patientsoutofTime.org. Your healthcare professional can find a accredited course, small courses, short courses, 1 hour courses, about 1 CME, one medical credit for a very reasonable fee, online, at their convenience, at home, at themedicalcannabisinstitute.org, themedicalcannabisinstitute.org. And keep in mind, at high noon on Wednesdays on timeforhemp.com, we have a show where we interview cannabis patients and their caregivers, and those are dogs in the background. It's okay. It's supposed to be there. Interview patients and their caregivers about the use of medicalcannabis.com. And until then, thank you for listening. This is Al Byrne for Patients Out of Time. Take care.
And I want to remind people that we are heard 24 hours a day, 7 days a week, all around the world on iHeartRadio, Tumblr, SoundCloud, and at timeforhemp.com. You can also use that plug-in for your website if you are building it. Please find us on Twitter and Facebook. And remember, the next time you hear me, you'll know that it's Time for Hemp.
Look at all that money, yeah, the money that they spend. Take another.
You are listening to the Time for Hemp Global Broadcasting Network. The only broadcasting network dedicated to ending the global war on drugs on iHeartRadio.